All right. So let's go ahead and start sharing your PowerPoint, and everybody welcome Chris Russell. Thanks, Chris.
Okay, this is Chris Russell. Thank you so much. Thank you so much to Marilyn and Robert, Marcy, Donna, Dana. I hope I'm not missing anybody here, but thank you as well to the interpreters and the captionists. I think you can see my PowerPoint now. I really appreciate your inviting me to join you. I'm going to try bringing up my chat box and let's see if that works. Oh, good. It does work. So I'll just do a very quick intro and I'll get right into it. The only housekeeping part on my side is that I welcome you to please just type in your questions, your comments, your ideas, your examples, your points that you want some clarification on right into the chat box as we go. I always have way too much content for the amount of time that we have. And so we'll get through all of this truly critical information, but we usually don't really have time for questions at the end. So much better to just ask as we go. So I'm the project coordinator of the New York Deafblind Collaborative, the Deafblind project in New York. I have a background as a TVI, teacher of students with visual impairments, as well as a classroom teacher working with students with visual impairments, deaf blindness, and complex communication needs in particular. I sort of fell into this work with CVI because I realized that it was a big area of need. And then also because I realized that as a TVI, I was sort of somewhat prepared to work with these students. But the more students that I saw with CVI, the more I realized that I really didn't have enough comprehensive understanding to be able to apply that to each and every individual student. And I sort of had ideas, but not true sort of like expansive skills. So I just put my time into learning about this. And the more kids that I met, the more families that I met, and the more professionals that I worked with, the more I sort of, honed my own skills and opened up my sort of, my understanding a lot broader. So my hope is to sort of share that that experience as well as that perspective with each of you, no matter what your background is and what your current role is. That in mind, does everybody have access to the chat box? I think so, right? If you have access to the chat box, can everyone just type in just what your role is? I'm not going to read them all out, but just so I can sort of see, and so everyone else in the room can see kind of the variety of different folks that we have today. Awesome. And I'm just seeing all of them pour in, and we have lots of parents. I'm so happy to see lots of parents here. I'm seeing lots of TVIs, TOD, speech, OT, administrators, service coordinators, Deafblind project, right? Interpreters, family engagement coordinators. This is awesome. Some folks that work in EI. So that is always my hope, is that we have in the audience in these workshops, that we have a really like a representative of a comprehensive collaborative team. That's what we need to appropriately support our students. And we're going to see what's specific about collaborative teaming for CVI. So let's just get right into it. Just a little bit of sort of background context is that the way that we are looking at CVI specifically is definitely based in the work of Dr. Roman Lancy. And that is to say that Dr. Roman Lancy's work developed a pretty comprehensive approach to assessment and intervention of students with CVI based on 10 specific characteristic visual behaviors or characteristics, and across 3 phases of severity of CVI or impact of CVI. And it's a very thorough and holistic way of understanding CVI as it applies to each and every student. So that's sort of like the framework that we're using to understand this. I'm going to talk you through the characteristics and the phases in particular, and then a little bit on intervention, a little bit on assessment. In the next session, we're going to focus more intensively on some of the unique work that I've done around applying this content to communication modalities and to AAC. just credit where credit is due. All of the examples that I'm sharing with you today, the photographs and the videos, they all come from my collaboration with various professionals and family members of students with working with or of students with CVI. And it's just instrumental to me to be able to learn from different professionals. You see speech pathologists in that list, TODs, TVIs, Deafblind project folks, as well as parents who have been really helpful to me. So just getting a shared definition. And yes, the event is being recorded. I think they can give you more info where it'll be available. So let's just get a shared definition for everyone. I'm sure everybody is coming to the table right now with different degrees of prior training and knowledge. CVI essentially refers to vision loss or differences in visual processing that are not due to anything going on with the eyes. And typically the eyes are functioning, typically or normally. It is processing of vision in the brain, and specifically in the visual cortex and the visual processing centers of the brain, where the difficulty is being observed. And so it's interference with or difficulty with understanding the visual information. The visual input is fine, the processing is atypical. CVI is now understood to be, and has been for at least 10 years or so, the leading cause of childhood visual impairment. And I used to say like living in the Western Hemisphere or living in, the US or something, but I think it's more accurate to say living in countries or even regions of this country that have access to quality neonatal healthcare. And the emphasis on access to quality neonatal healthcare, it's about the primary causes of CVI, which really are related to anoxic brain injury or hypoxic brain injury that tend to occur around very low weight or very premature birth. So these are simply kids who, for the most part, kids who were not surviving the traumatic birth 20, 30 years ago, and are now surviving at a much higher rate due to quality neonatal healthcare, but the chance that they may have CVI and some other variety of a host of different issues is much higher. It's not a definite, but it's much higher. And we'll look at some of those causes. CVI is completely different from other non-brain related visual impairments. What we have here on the screen on the top left is a basic cross-section of the structure of the eye, right? Looks familiar if you're a TVI. This is about as basic as you can get in showing the different major components of the eye. In an ocular or eye-related visual impairment, if we know what the condition is, and we know where the impact is, and we know how severe it is, then we have a pretty good sense of how it impacts vision. So for example, if you have an opacity or a spot that's dried or dead in the lens of the eye, right there in the lens, that would be a cataract. And we know that a cataract can cause reduced contrast sensitivity, blurring of vision. It can cause photophobia in some cases, and it's definitely going to cause some acuity loss and probably some field loss, right? Totally different from a child or an individual who has a retinal detachment, or let's say even retinitis pigmentosa for your individuals with Usher syndrome with retinitis pigmentosa. That's deterioration of the cells in the retina, in the back of the eye. It's going to cause tunnel vision. It's going to cause night blindness, difficulty with contrast sensitivity, but it's not necessarily going to affect acuity loss as much as it affects field loss until it gets really further progressed, right? Totally different impact of two different ocular visual impairments. And we know what the impact is just by knowing the condition, where it's located in the eye, and how severe it is. We cannot do that with CVI. We cannot look inside the eyes and see what the issue is. And we actually can't really even look inside the brain and see how severe the issue is at this point. At this point, an MRI can tell us whether there is likely to be CVI or not. So we can see some red flags for CVI, like in certain conditions in PVL, which we'll talk about in a minute. We'll tend to see enlarged ventricles in the brain. That's a sign that your child has some damage there, some deterioration of white matter in the brain, and may have CVI. but we can't look at that MRI and say, looks like phase 2 to me. We're not there yet. And so instead, we rely on functional and observational information from a functional vision assessment. So in that sense, the educational field is actually able to give information that is, that is reliable and functional in a way that the medical field can't necessarily do for us related to CVI at this point. Different from ocular. Children with CVI can have additional ocular visual impairments, and this is a whole other conversation, but I would say very briefly that the ones that I tend to see most often are some kind of ocular motor impairment, usually like a strabismus or an amblyopia. Eye is drifting out or eye is drifting in. And I'm not sure 100% why that's happening. There's still more research needed. But my guess would be that if you have a child who has a strong visual field preference in early childhood, they're only looking at things on the right side, probably what's going to happen is that the left eye in development is going to not be used as much, and it may start to drift off. It may start to deteriorate in acuity. So you may have like an acquired ocular or ocular motor issue as a result of a strong field preference in early childhood. Kind of a different issue, right? But if you have questions about that or kind of want to look more into it, please do reach out. And I should say too, I will share the PowerPoint. You can have access to the PDF, so you don't have to like take phone shots or anything right now. And if you have questions, you're welcome to reach out to me. I'll give you my email. Okay.
Hey, Chris, this is a good time. Let's go ahead and switch interpreters, please.
Cool. Thank you.
Awesome. Sure. Good time for you to get some water. All right. You're good to go.
Okay. Thanks. So CVI is suspected, and there have to be 3 criteria. There must be a history of, I think the better way to say it is neurological event. There's some sort of a neurological event or condition that can explain what's happening, but it's some sort of brain injury or malformation. And we'll look at some of those, what those might be. There must be a clinical eye exam, and the clinical eye exam is basically telling you whether or not there is an ocular issue that that can explain what you're seeing. So we're almost like the clinical eye exam should rule out other things that might be causing the abnormal use of vision that we're seeing, or to identify if there is an ocular visual impairment as well. And then perhaps most importantly, the presence of unique visual characteristics. And that's where observation plays a unique role in the diagnostic process. Again, diagnosis needs to be conducted by, needs to be done by clinical professionals, but educational professionals and family members, you can make note of all of these behavioral characteristics you're observing and give that information to the clinical professional, who is then able to say, oh yeah, well, the other pieces do align. So the fact that we're seeing these unique visual characteristics looks like CVI to me. But you can see with this criteria, it's not really like a clinical or quantitative diagnosis. It's much more of a functional diagnosis and an alignment of factors. Here is just a short list of medical history significant for CVI. The top 2, and if I had my camera on the interpreter, and I always enjoy watching the finger spelling of these top 2, hypoxic ischemic encephalopathy, right, or HIE, or paraventricular leukomalacia, PVL. Those are both conditions involving deterioration of white matter in the brain following a lack of or too much oxygen in the brain, both at risk during premature low weight birth. Okay, so we're talking like 23 to 28, 29 weeks gestation. Those are events that can cause CVI. They don't always cause CVI, but those are probably the 2 most common causes. Seizure disorders, especially if they are severe and impact that particular area of the brain. Strokes, intraventricular hemorrhage, infections, metabolic disorders, structural anomalies, even some chromosomal disorders that I think we need more research on chromosomal disorders that could cause CVI. But one in particular I'm thinking of is CDKL5. If you've heard of it, CDKL5 is a specific chromosomal condition, chromosomal disorder that used to be, and maybe still is, misdiagnosed frequently as Rett syndrome because it looks very similar to Rett syndrome. But Rett syndrome tends to only occur in girls. CDKL5 is both boys and girls, and both look very similar. CDKL5 has a high risk for CVI. Now, cerebral palsy is not a cause, it's an associated condition. Usually, I think because whatever caused the cerebral palsy, like a stroke, a prenatal stroke or a perinatal stroke, could also have caused CVI. And you see at the bottom there in italics, prematurity is not a cause, it's a risk factor. So children who are born, very premature or low weight birth, should be, it should raise a red flag, and we should look and say, well, was there any event that happened around there? Was there HIE? Was there PVL? And let's figure that out. This is information that I think it's good to just be aware of, but it's also, good to think on a more systemic level. How can we inform our healthcare systems and our neonatal and follow-up clinics to look out for this and to identify kids earlier? Okay, so a couple of frequently asked questions that I get and that you probably have gotten to. The clinical eye reports were normal or unable to test, but I know that my child's visual functioning is not typical. Okay, you go to the eye doctor and the eye doctor says, eyes look fine, and so there mustn't be a problem. Or I've heard unable to test, right? This child has multiple disabilities, doesn't communicate using symbolism or language, and we can't test the child. First of all, if anybody ever tells you that a child is unable to test, all that means is that that specialist doesn't know how to test the child, and you go find somebody who does. There's no such thing as unable to test. Unable to test means I don't know what I'm doing here. And it doesn't mean that the person isn't a skilled professional. It just means that they don't really, this isn't necessarily their area of expertise. And maybe they don't have as much experience with children who have complex communication needs and other sensory challenges. So go to somebody who does. So these are the questions to ask yourself then when you hear these things. Does this clinical vision specialist, whatever their profession is, ophthalmologist, optometrist, does this person recognize or diagnose CVI? And I actually recommend that families ask that question before you even confirm the appointment, right? Call the office and say, hey, I'd like to make an appointment, with this ophthalmologist. Do they recognize or diagnose CVI? No? Okay, thank you. I'm going to try someone else. Go to someone who does. And in your own states, in your own areas, you're going to be the best resources for each other about who does. It might be a neuro-ophthalmologist. That's an ophthalmologist who has unique training in neurological processing disorders, but not all neuro-ophthalmologists are highly skilled in CVI either, because sometimes that profession is more focused on processing disorders that would usually be treated by a reading specialist or a learning disability specialist, like dyslexia or something else like that. And then importantly, again, clinical information gets us a diagnosis, but it doesn't really get us that much in terms of what to do next. You have to follow up clinical assessment with functional vision assessment. And we'll talk about that a little bit. Now, and please feel free to interrupt me and if we need to switch interpreters or whatever too. Now, what about this? The functional vision assessment does not address CVI. If that's the case, ask a similar type of question. Does the TVI or low vision specialist who conducted the functional vision assessment have training in CVI? Do they specifically have training in the CVI range assessment? If they're not using the CVI range assessment, which is their choice, you can't actually mandate that a TVI use a certain assessment protocol, But what you can mandate is that the functional vision assessment addresses the unique characteristics or the unique impact of CVI. So whatever protocol they use, whatever assessment tools they use, the FVA should address the unique impact of CVI, which is different from the unique impact of ocular forms of visual impairment. You can ask for the CVI range as an appropriate assessment. Again, you can't mandate that that specific tool be used, but you can ask for an FVA that addresses CVI, okay, because that's the child's condition. Just like if you have a child with retinitis pigmentosa, you want an FVA that's going to address the unique impact of retinitis pigmentosa, not that's going to talk about the impact of glaucoma or cataract. So that's sort of the focus there. Anybody with training can administer CVI range assessment. Doesn't have to be a TVI. However, only a TVI or another vision service provider can conduct an FVA. So CVI range assessment is a useful thing to have in your toolkit, no matter what your role is. If you're a speech pathologist, an OT, a PT, a classroom teacher, but you're using it for functional purposes. You're not using it for as a formal FVA. That can only be done by a TVI or a vision service provider. Okay, so that's a little bit of FAQ out of the way. Why is it so important to identify and assess CVI, and what's unique about CVI? Well, unlike ocular forms of visual impairment, there are specific interventions that we're using with CVI, the intention of which is to actually improve the child's visual functioning. That's different from ocular, because children with ocular forms of visual impairment, we're not expecting that with training and with intervention that their vision is going to get better. We're not trying to improve their vision. With students with ocular forms of visual impairment, we're trying to teach them compensatory skills and the use of technology, the use of other strategies, mobility strategies, visual efficiency strategies, to get around the fact that they have a visual impairment and to succeed and be able to access information anyway. Now with CVI, it's different, because with CVI, we're actually trying to improve vision in the brain. And the interventions that we're using have to be based on assessment, because we're using different approaches depending on where the student falls on this range of visual functioning. It looks totally different in phase 1, phase 2, phase 3, and we'll look at that. Intervention has to be a team effort, and that's why I'm always so happy to see a broad and diverse collaborative team represented in these workshops. It can't just be the TVI in like a 2 times 30-minute a week session. That's not going to be enough practice for the child to make progress in their neurological visual functioning. If you think about it, the brain cannot make growth and improvement in a 2 times 30 session. That must be done integrated all throughout the program, everyone buying into it. And these interventions, they should never get in the way of what you need to do as your own unique discipline. They shouldn't get in the way of your goals as a speech pathologist. They shouldn't get in the way of your goals as a PT. They should actually help you to make your goals reachable by using vision within those goals to the degree that the child can. So this is a holistic, integrated approach. It's not siloed. It's not, it's not each discipline for themselves. So how can we integrate CVI intervention across the whole day to the degree that it's possible? Okay, everything I've talked about so far in this first 25 minutes, it's all summarized in this little 2-page fact sheet that I made. The purpose of which is just so that you don't have to explain this stuff yourself. You have some language to use, you have some resources to show people, and I'll share with you the link. Actually, I think I have it right here. Okay, yeah, so these and a couple of other things I'll show you are up on the Paths to Literacy website. It's in the chat box. This is just a 2-page little fact sheet. It answers some of these basic questions, gives you some shared terms. It asks you it gives you some of the frequently asked questions and maybe some responses you might have to that. And there's also links to additional resources there too. So a broad range of resources that might be helpful to families and professionals. Okay. Are we good? Do we want to switch interpreters? Maybe a few more minutes. Just feel free to interrupt me. Okay. So we're not going to get too deep into neurology here because I don't understand very deep in neurology. But I do think it's important to get a basic understanding of what exactly is happening in the brain. And maybe most importantly, because we cannot do a simulation of CVI in the way that we could do a simulation of an ocular visual impairment. Put on some goggles or watch a video, that simulates what it might look like. With CVI, we can understand it and understand what it might be like to have CVI by knowing what's going on in the brain. So there are two visual processing streams in the brain, and these streams are basically how we make sense of what comes in through our eyes. Visual input comes in through our eyes in light and wavelengths. It goes through our optic radiations and then goes back into the processing center of the brain. And it passes through these two streams, almost like highways or roads for processing vision at the same time, simultaneously. In typical vision, we're using these two streams together all the time, every time that we open our eyes and look around. There's the dorsal stream, which gives us information roughly about kind of where things are, but not what they are. The dorsal stream gives us information about movement, form, light. It gives us very little information about acuity or detail. The ventral stream gives us information about detail, and it helps us to figure out and categorize in our brain what it is that we're looking at. So if you can see my camera now, if you can't, you can play with your controls so that you can see my little camera. You can see my camera now, my video. I'm holding up this little yellow toy truck. Okay. I'm holding it about 2-3 inches to the right of my eye. I'm looking straight ahead. I'm not looking at the toy truck. All right. When I'm looking straight ahead, I can still see that there's something here. But what can I tell about it? If I'm not looking directly at it, if I'm not making eye to object contact, I can tell what color it is. It's bright yellow. If there's something moving, I can actually see that movement. If I shine a flashlight on it, I can see that bright light. And it's actually, I can see it really well. I can't see the detail. I can't tell, if I didn't know it was a truck, I might not actually even be able to identify what it is. I certainly can't tell all of the little tiny details on it and the components. Now, if I shift and look directly at it and I make eye to object contact or direct visual fixation, prolonged visual fixation, now I can see all the details. I can see the what. I can
Yes,
read
this
the
is
word.
Donna. We're going to go ahead and do an interpreter switch.
Okay, cool.
Okay, you're ready to go. Thanks, Chris.
Thank you. Yes, you can see the link I posted in the chat box for the fact sheet. It's one of the links on that page. Okay, so if I'm looking right at something, this little toy truck, now I can read the text on it. I can see the windows. I can understand each part, right? So you can see where this is going, right? The dorsal stream gives us rough information about where things are and the form of them, the bright colors, the movement, the lighting. The ventral stream gives us information about what. So what's happening in CVI? Progress in visual function in CVI, it starts with almost no use of either, but maybe a little tiny bit of dorsal stream. And with a little tiny bit of dorsal stream, maybe we can see like a bright red, shiny, reflective pom-pom in our right visual field, right? Now, as the child makes progress in their visual functioning, they're strengthening their dorsal stream. Then they're starting to see the beginning of the use of their ventral stream. And we know that they're doing that when they start to make eye to object contact, when they're looking right at something. That's a sign that the ventral stream is starting to be used. And then as they continue on into the CVI range, on into phase 2, phase 3, later phase 2 and phase 3, Then it's all about strengthening the ventral stream. So that's what's going on here when we talk about making neurological visual progress. Here's just a quick little diagram that shows this dorsal ventral stream thing. You know, could spend more time on this, but let's just keep going. The other simulation that I would give you is, and this is what I've done in classrooms, like for classroom teams, because it's, you know, hard for people to grasp really when we talk through characteristics and all that. It's hard to like look around the classroom and think, well, how does that apply here? What do I need to do? It's easier if you can give someone a simulation. So this is a simulation I like to use, which is just get like, you know, a mug or a cup full of pens. There's one in every classroom or office, right? And same thing I just did with the truck. Now hold it up and don't look right at it, or like leave it on the table and don't look right at it. Look a little bit to the left of it or a little above it or a little to the right of it. Don't look directly at it. And this cup, this mug of pens and pencils that I'm holding up now, if you notice, they're all black or gray or white pens. There's nothing bright or colorful there. So let's say that I want to get this one, which is this gray one that I'm holding up. Put it back in this complex array. If I want to pick that gray one, I'm not looking at it. I'm looking 3-4 inches to the left of it. Can I actually find it? Can I reach and find it? I can't actually. It blends into this complex background array. And what I end up doing is making mistakes. I pull out something and pull out another one. Maybe I'm even feeling around, and then eventually I find what I'm looking for, okay? Because I'm not using my ventral stream. This complex array is too much to deal with. That same thing, that same simulation with this bright yellow highlighter, I'm putting the bright yellow highlighter in there. Now let's try it straight to it. No problem. Got it. Why is that? Because in my dorsal stream, it was very easy for me to see the bright saturated yellow color. It's even easier if I don't have this busy array. So actually now I'm going to take all the pens out except for the one that I want. Now can I do it? Yeah, no problem, right? So I have two adaptations there. I need to figure out which one my student needs. Is it, or maybe both, is it no complex array, take out the complex array, or is it the bright color, or maybe is it shining a flashlight on it, or is it adding some movement to it? Which one is it that's going to help your student figure out what is it that I'm supposed to be looking for and finding there? And you can do the same thing with your phone, right? If you think about it on your phone, you know, everybody has a smartphone and you have all of your apps on your screen. If you're looking at your phone indirectly, if you're looking 3-4 inches to the left of it, how much can you actually do on your phone? Can you pick out a specific application? Can you enter in your passcode? And are you doing that based on motor memory, or are you doing that based on actually being able to see the detail? I think you'll find that the only things you can do on the busy array of your phone without looking right at it are things based on motor memory, or the brightest, most distinct, most visually distinct things. Like I could find the Messages app on an iPhone because it's bright green and it's on the top right. So I kind of know where it is, but also it pops out because it's bright green. That gives you a good idea about what communication systems might look like for a student. We'll talk about that next week. CVI has been described as like looking through a kaleidoscope. And I heard this example from Dr. Roman, who I believe was quoting a teenager who has CVI from a traumatic brain injury. And the teenager had said, because the teenager had a memory of what it was like to have typical visual processing before the traumatic brain injury. And after said that the whole world was like looking through a kaleidoscope with CVI. And if you think about that, think about looking at a busy preschool classroom through a kaleidoscope. It would be very overwhelming. But think about looking at a blank wall, white or black, a bright red pom-pom with nothing else around it. Now that would actually be pretty easy to look at through a kaleidoscope because there's reduced complexity and there's a bright saturated color and a pretty solid object that stands out. So again, you know, these are analogies. These are ways of sort of thinking about it. It's not perfect. It's not really the same as putting on goggles with an ocular visual impairment, but it's powerful enough to make people grasp, yeah, there's some unique considerations here. And, we really do need to look around the room and think about what needs to be adapted. So it's useful to have these kind of things, even if they're kind of, a little bit of like a hyperbole, right? Okay, so let's get right into it. And I think we're good on timing. We've got like about 50 minutes. And what we want to do is really definitely get through the characteristics. That's the most important thing. Characteristics and phases. And then we'll see how much time we have left for anything else. When we talk about the CVI characteristics, what we're really talking about is how does each characteristic impact visual functioning? How does each of these characteristics individually and then combined impact the child's ability to use his or her vision, to access information all throughout the day? Note that the characteristics affect vision differently as the child improves in their visual functioning, right? And it's all about dorsal and ventral stream. It's all about what we just explained with the dorsal and the ventral. They look differently in each phase. The CVI range is a scale from 0 to 10, but there's no such thing as 0, and there's no such thing as 10, because with 0, you would have no visual functioning. No child with CVI has 0. There's always something more than 0, even if it's just a tiny, tiny bit. And the most significant, the most severe that I've seen, which was just a little bit above 0, was a child who's only able to look at this bright red glow stick in a dark, quiet room, 2 inches away from his right eye, moving back and forth after like 2 minutes of doing that. And then we saw a clear visual engagement. Now, it took a while to figure that out, right? Because who's going to create all of those circumstances? Everybody else had assumed the child is totally blind, can't see anything. But with some thorough assessment, we figured it out. Oh, no, he can see that. So that's where we're going to start. We're going to start by giving him more practice doing that. And we know it doesn't sound like the most functional thing, turn off the lights and wave the glow stick for a half an hour. But what we expect is that if he has some opportunity to do that, not all day, every day, but, in downtime at appropriate times, building up throughout the week, he's going to show progress. And sure enough, that student, with enough of that practice and exposure to looking at something that he could see, suddenly we start to see, oh, now he doesn't have as much of a processing delay. Now he sees it immediately. Oh my God, now he's able to see it in his left eye too. Now he's able to see it a little further away. Now he can look at a green glow stick as well as a red one. And that's progress, right? That's actual neurological progress. And eventually we're expecting that to become, way more functional and practical for his day. So here are the 10 characteristics, and we're going to go through each one of them. And that's really the main goal for today, is to have a thorough understanding of the characteristics. What you're going to find is that after we've talked about the first 5, we've already pretty much talked about all of them, because they do connect and they overlap. But we'll go through each one. So, and again, please feel free to ask questions if they come up. So the first characteristic is color preferences. Okay, children with CVI tend to be able to see bright, saturated colors. Black and white, gray tones, pastel colors are much harder. Now, usually the go-to thing if you look at like those infant, the baby books that are like bright, that are like really sharp contrast, the black and white shapes, those are not going to be as helpful for kids with CVI. What they need is bright, saturated colors. Now, children with CVI tend to have a favorite color when they're a little lower on the CVI range. So let's think about each of these characteristics with like an example in, phase 1, early phase 2, and then phase 2 on into phase 3. So on the lower side of visual processing, it may be that the child can only look at something that is a certain color, only can look at something that's bright red, only can look at something that's bright yellow. As they make progress in their visual processing, they can look at any color but they benefit from the use of color to highlight important information or to provide an anchor for their visual attention, to show them what is it that we wanted to look at. Just like this pen, this yellow highlighter, it was an anchor for visual attention amongst this very complex array of other pens. Okay. An interesting fact is that you actually don't even need to have a visual cortex to see the color red. You can process the color red in the very front part of your visual processing center. Information doesn't even have to go to the back of your brain to process the color red. That's probably, if I had to guess, that's probably just something that's happened through the process of evolution, right? Because in nature, things that are bright red are usually things that we want to stay away from. So our brains are already structured to be able to process that color red without even having to think or deal with it. And with dorsal stream alone, you can get information on color, right? We can see what color it is, even when we're not looking directly at something. So some examples, you have a little girl with CVI who's looking at a bright purple, reflective pom-pom, right? One solid single bright color. A little boy who can only look at single colored objects. If that was a multicolored ball, it would be harder to look at, but it's a single colored bright yellow ball. Elmo's a good example, right? Bright red, solid color, not very much detail, pretty easy to see. Slinkies tend to be, easy to see for children with CVI, a little lower on the range, phase 1, early phase 2, because they tend to be bright saturated colors, and also because they have a movement quality, which we'll talk about briefly. Now, a little later in the CVI range, and next week I'll show you the video that this picture is from, you see a little girl with her speech pathologist who is looking at a tangible symbol, right, a communication symbol. And we have a reduced complexity of the array. We have this red rectangle on the left side, which is anchoring her attention to that place to be able to move the cue over and say, this is what we're doing now. This is what we're doing next. So in this example, color stands for an idea or a concept, and that bright use of color is helpful for her to be able to anchor her vision and focus on that concept. This is one of my favorite ones. It's a classroom where a student with CVI was frequently disoriented and had difficulty figuring out the route from his desk to the door, right? Especially when things were busier, when the classroom was busier. So instead of, I think the instinct would be, okay, let's paint the door red, or let's put red tape across the whole door. That's overkill. You don't have to do that. All he needed was a little bit of red electrical tape around the light switch to the left of the door. So when he's doing that kind of shifting look, trying to move and figure out where he is, he would see that bright red anchor, and that would orient him. It's a landmark, right? It's what orientation mobility instructors use as a visual landmark for understanding your place and your orientation in space. If you think about it, that's, yeah,
Chris, this is Donna. I'm sorry. We're going to do an interpreter switch.
Cool, thank you.
Okay, we're good.
Awesome, thanks. So if you think about it, this light switch example, it's the same as what we have in a building or, say a theater with the exit sign, right? The exit sign is bright red. It also is backlit. It's got a bright light. And when you're disoriented, imagine if you're in a busy, crowded place and there was an emergency, a fire, something, the lights went out, you would shift around and look and you'd find that bright red visual target. Now, this is exactly how we want to think about CVI interventions as they relate to color. You want to have something that's bright, saturated, easy to see, and easy to be able to point out, what is it that I'm supposed to be looking for here? Oh, that's where the door is. Oh, that's where the instructional material is. That's where the sight word is. So on the bottom left here, you have some adaptations to instructional materials. On the left is a book. That's what do you call that? I forget that. What do you call that book name? Blanking on it. That's the Eric Carle book, right? So you have a little bit of it's Brown Bear. So you have a little bit of a tactile adaptation, a little bit of the white fur, because this is a student in late phase 1 who still needs a little bit of tactile support to be able to orient towards something in the book and get that concept of, this is the dog is soft. There's a bright red reflective collar that the dog has, and that's what orients the child to, there's where the dog is. Can we find the collar? Now let's find his face. Now let's find the fur. So it's just a slight little use of color to anchor the child's visual attention to a concept. The one in the middle is a communication card that the team was using in a preschool morning circle activity for the song Head, Shoulders, Knees, and Toes, right? So the child with CVI, who's in late phase 2, needed just a little bit of that red puff paint or red outline for the head, the shoulders, the knees, and the toes. And it was just enough of a little adaptation for her to be able to focus on each part as they related to the song. So enhancing her participation in the activity. Okay. The use of bright saturated colors, and most importantly here, we'll get into this next week in communication, on a, 2-symbol array for, identifying the weather. Sunny and cloudy look very visually distinct from each other. And so that's the use of 2 bright saturated colors, but they look very different. They're not 2 blue ones. They're a bright yellow one and a bright blue one. And those colors really pop out. So we'll talk about that more next week. Okay, the second characteristic is movement, the need for movement or preferences for movement in order to attract visual attention or in order to sustain visual attention. So the child is only seeing something if it's moving, or maybe movement just helps them to look at it the first time and then they can see it. It doesn't need to keep moving. Children with CVI sometimes only look at things that move, right? That have something spinning or moving back and forth, or that has a movement quality, like something shiny or reflective, right? The pom-pom is interesting because it's got light, bright color, and the reflection of light actually causes movement. This often helps children with CVI with mobility, because when the child is in motion, the world is moving around them and it's easier to process. So I've heard a lot of people say that a child did much better with, finding things when they're out in the hallway and moving around, whether it's being pushed, in a wheelchair or stroller or Riften chair, or, ambulating. When the child's in movement, they can find things. When they stop, it's harder to find them. And that's because of that characteristic. The other thing that you might see is you might see a child do a moving behavior. They may rock their body back and forth, or, front to back. They may move their head back and forth. And that's very frequently misunderstood as a self-stimulatory behavior, or like a vestibular behavior, when in reality, for kids with CVI, it's because when I'm moving my head, it's easier to see the world, right? It's easier to process what's in front of me. If I stop, it's much harder to tell what's around me. So if you see a child doing that, what you might try doing is pick up something that they might be wanting to look at. They might be moving in order to see. Maybe this toy car is in front of them, and move the object back and forth. And what you're going to see is the child stops moving, right? Because they don't need to move anymore now that the object is moving, now that the world is moving. And that, to me, the first time I saw it, it was like a big light bulb went on of like, oh, that is what it's all about, right? That's that issue with movement. And that also is that issue of really misunderstanding kids with CVI and qualifying their behavior as, something else that it's really not. It's not an autism behavior. It's not a self-stim. It's a compensatory strategy for processing the world. So that's a big aha for me. I'll just share very quickly. I want to keep it going, but one of the really aha moments that I had recently with a student with CVI was this young student was in the hallway in his wheelchair, and he's maybe in late phase 2, and he doesn't do any light gazing. He's sort of past that, but he was looking up at the lights, and he goes, "What's up there? What is that?" And the teacher, the TA, said, "What do you mean, the light? well, there's a light up there. And he goes, no, no, not the light. There's something moving up there. And the TA looked and was like, I don't think so. And looked a little closer. And there was actually a strand of hair, a single strand of hair hanging from, or, you know, like attached to the light. We never would have noticed that, right? The student with CVI noticed it because for him, that movement, he described it as like, it was like a wave of movement that he saw up in front of the light. So that was like a real aha too, that was like, wow, that's really a very different way of processing the world. And it's a way of processing movement more than detail, right? What he saw was that movement, not the detail that we look at when we look up at the light. So again, it's not about acuity, right? His acuity was not impacted. Instead, he was able to see movement better than he was detail. Okay, so oh yeah, so just further along the CVI range, children can see things at near without movement, but they benefit from movement at a distance, or they benefit from movement with the most unfamiliar or the most complex materials. So kind of earlier on the CVI range, we may only be looking at things that have movement like pom-poms or, you know, mobiles that are very simple and have bright colors or reflective qualities. Okay. So again, we'll kind of show how these characteristics overlap too. And, you know, they do cross over. So the next one is visual latency. Children with CVI may have a visual latency or visual processing delay. That is just simply the length of time between when something is shown and when the child looks at or orients toward it. It's different from a motor delay. It's different from a cognitive delay. We're only looking at whether the child even recognizes that it's there. It's not about how interested the child is in the thing. So somebody asked me, well, you know, don't kids with autism not look at things too? And the answer is no. Children with autism will take a quick look and decide, I don't need that. I'm not interested in that. But if you're moving something bright and colorful, a child with autism will quickly check it out and then they'll go, nah, I'm done. I don't need that. A child with CVI won't even recognize that it's there until you give them some time to process. And that's time to process without prompting, without any additional verbal or physical prompting. And that can be anything from, you know, a second or two all the way up to several minutes, or the need for warm-up time. That, you know, I didn't look at it at first, but after a while of interacting with this thing, now I can look at it right away. So further along the range, that latency decreases with warm-up time, or we only see the latency when the child is tired, stressed, overstimulated, or post-seizure, right? Which is sort of the same as overstimulated or tired. So I think these pictures here, this is a nice example of that processing delay and also that kind of unique way of looking that we often see with kids with CVI who are in phase 1 or in early to mid phase 2. Got the slinky in front of her, it's there, she doesn't realize that it's there, she doesn't realize how many seconds, 2, 3, 4, and then she looks. But when she looks, it's an indirect look. And that still counts as a look. Right? Sometimes it's a little subtle. Sometimes it's hard to tell. Am I just seeing what I want to see? Did that happen? Did that not happen? That's okay. Try it out a few more times. Try it in different locations and start to get a sense of, was that a look or was it not? And with some thorough observation, you'll be able to tell. Okay. So, and all you can do for processing time is provide it, right? Just provide extra wait time. That's the way that we support that if a child needs it. Children with CVI have unique visual field preferences. And I used to say field losses, but it's not field losses. It's a preference. A field loss means that there's no vision in that area. A field preference means that the brain has an easier time seeing things in a certain visual field, has a harder time seeing things in other visual fields. The typical progression is one strong peripheral field. It could be either right or left. I'm not really sure why one starts over another. I don't think we really have any evidence of that. I've seen either one. And then both right and left, and then upper, and then central, looking right at something, right? That's when you start to make eye to object contact. And then finally, the lower visual field is usually the last to resolve, or it doesn't resolve at all for kids with CVI. That's why one of the go-to accommodations for a child with CVI is a slant board. Materials almost always really need to be positioned on a slant board in an educational setting, or if it's an object that's going to fall off a slant board, on a stand, or even like I've seen people use like an upside down, container or bin, or like a shoebox. Just get it a little higher up off the surface if you can. Okay. So here's just some quick little examples of visual field preferences. Right side. This was an interesting one on the right here of a, this is like a morning circle routine where the students are going around and they're recognizing a photo of themselves or a picture of themselves to say, I'm in school today. Who's here? Who came to school? I did. But for this little guy, he's not yet ready to look at photographs. So he's looking at a mirror that the teacher's holding in front of him. And they did something really clever here, which is that they used that black trifold board behind him instead of like in front that we usually use it to present materials. It's behind him so that when he looks in the mirror, he has a nice black background behind him, right? As opposed to whatever busy stuff is on the walls. That was a clever way to just think about, reducing background array. Okay, I want to show you some short little videos to look at how visual fields may look kind of different.
Chris, this is Donna. I want to give you a 30-minute time warning, and
Awesome.
I'll do an interpreter switch before you show the videos.
Perfect. Thank you.
Okay. Okay, you're good to go.
Okay, thank you. I have to go out and then back. So I'm going to share. Okay. So as you look at this video, thank you again to the parent of this child who allowed me to show the video in the training. As you look at this video, just look at what's going on with her visual fields, right? And what you're going to see is I think it's a caregiver who brings the little bright blue object into her right visual field, and watch what her visual regard looks like, as well as her visually guided reach, which we'll talk about in a bit. And there's no sound that you need to hear, by the way.
Thank you for purchasing. Now we won't talk anymore. Well done, Peppa.
What shall I film first?
Film me.
Okay, Peppa.
Hello, I'm Peppa Pig.
Okay, so interesting look at visually guided reach. Now we just see it again. I'll use the little, right, go slowly so you can see. We see that she saw that it's there with her right visual field pretty well. And she actually reached toward it. She looks while reaching. And then as soon as she's got it, as soon as she finds it tactily, she looks away. Okay. Now let's look at this other one. Okay, same student, now outside in an O&M routine, how she uses visual field here.
You want to? Come on down. You like to walk on the grass? I like the way you're looking down. Okay, that's good, Christina.
Okay. Wow, so look, lower visual field is very hard. So it's actually easier for her to not look at all when she's walking down those stairs. Not looking. Look, here she actually appears much more like a child with ocular blindness, right? She's using her hand to feel. She's kind of using her feet to feel where she's stepping. But what's really interesting and exciting here is that change in surface, the bright green grass. It allows her to actually focus on that change of surface. That bright green grass gives her that information that she's able to visually get, oh, that's where the drop off is. So this is just a natural O&M, adaptation. It's a bright color marking a change in surface. Similar to what we have on platforms, the bright yellow platform on the train, on the train track. Okay, so let's go back to presentation. Okay, and I'll show you a few more of her as we go. But I thought that was an interesting one to look at, the difference between the strong peripheral fields, ability to use some central vision, and then lower visual fields, still pretty hard. It requires some significant adaptations like the bright green grass to mark a change in surface. Okay, so how about visual complexity? I've heard lots of people give this example, and I think it's an okay one. That the world for a child with CVI is like Where's Waldo, right? If everybody remembers Where's Waldo, it's totally chaotic and very visually complex. This is a very complex visual array. What we're trying to do, just like our example with the light switch or the exit sign or any of those other adaptations, we're trying to figure out what combination of adaptations and modifications need to be in place in order for the child to know what they need to be looking at and to be able to really get it. So is it a bright color, right? Is it that we need like a bright red highlight around Waldo? Now for one child, maybe that's enough. Maybe a child in late phase 3, all they need is that, and now we can take it away and they can find it without it. We just use it as a little preview. For another child, it's not enough. This is still way too chaotic and I can't deal with all this busy array. So I'm going to block off all of the busy background and I'm only going to show the little section that I'm looking for. So that's an example of complexity of the array, which can be 2D or 3D. In a 3D example, you have this basket of toys, basket of stuffed animals, right? They're all overlapping, they're all touching each other. It's very hard for the child with CVI to be able to pick out one individual toy here. They all blend together. And it's not about the size of these things. It's not about the contrast even. It's about the complexity of the array. When we take that individual toy out of that busy background and we put it against a simple background, it really pops out and it's very easy to see. Even further away, it's easy to see. Even smaller, it's easy to see. Because the real issue is the complexity of the array. And you can go back to your kaleidoscope analogy, right? Imagine looking at these things through a kaleidoscope. Imagine trying to get that Bert toy, right? Trying to get that toy by looking through a kaleidoscope. It would be very hard in the basket. It actually probably wouldn't be that hard against the chair. Okay, so that's complex array. And the 2D complex array was in that book, Where's Waldo? As compared to probably a much easier 2D complex array, which is, right, Clifford the dog, right, which I'm holding up a picture of. That's not so hard. That's a 2D array that has a bright saturated color. Even if the child can't see the detail on the dog, they can find where the bright red dog is, right? Okay. So one of the little kind of go-to assessments of complexity of the array that I tend to use, and if you look on the link that I shared above through Paths to Literacy, we just finished and posted about this example, so it talks you through it. Assessing 3D complexity of array with small objects. So take one of these little guys, this little, got him right here in this bag somewhere, this little bright orange goldfish toy, right? Not sure where it is. Take this little bright orange goldfish toy, and I'll just show the example on the screen. Put it against a non-complex array, nothing behind it, totally blank background. If the child can find that, now can they find the same thing against a slightly more busy array? But notice that it's still a black background, not complex background, and all of these other little toys around it are not the same color. None of those are bright orange, so that wouldn't be confusing. And also they're spaced at least an inch apart, so they're not going to appear to overlap like the toys in the basket did. Now, if the child can still find it there, can they find it here against a patterned background, right? But notice that the patterned background still is in contrast to the bright orange, so it still does appear to pop out, right? It doesn't blend in as much. Now, if they can find that, can they find it here against a more camouflaged background where the colors actually blend in as well, and it's way more complex? And then at any step along the way, can they find it? If they can't find it against, that certain array, can they find it if you shine a flashlight on it? So we're adding a little adaptation and say, well, complex array, it's too much unless you use light or unless you use movement or something like that. So this is just an example of a sequence of complexity. We're trying to find out for every individual child, to what degree can they handle complexity of array. Okay. And you could develop your own, or you could use something like that. Oh, the other thing I should say is that, people always say, well, my child or my student doesn't care about that plastic goldfish. They're not going to be interested in that. Well, find something that they are interested in. Maybe it's an M&M. Maybe it's an actual edible goldfish, right? Maybe it's one of their own toys, and develop a sequence like this that applies to your child, just to figure out where are they currently. Now that was the array. There's also complexity of the target. So the object itself has complexity. And if you look at these, you can probably figure out pretty easily what's the sequence here. The yellow duck is the least complex. And then maybe the little shape sorting toy, the ball, and then maybe the ring stacker. And then finally, that one on the top, that little tiny toy truck, that toy train is very complex, right? It's got multiple overlapping colors and tiny little details. And it would be very hard to figure out what that was unless you were looking right at it. So again, with a sequence, to what degree can your child or student handle complexity of objects? The next type of complexity is complexity of faces. So what you're seeing here on this screen now is an image with 12 blurred images of celebrities, right? And you can sort of play the game with yourself. Which ones can you find out? Ones can you identify, even with their blurred features? You're probably scanning it and trying to figure it out right now. And you could type into the chat box, does anybody know who number 5 is? Does anybody get number 5? All right, Ryan wins. And then I see you guys are following. Yep, it's Tom Hanks, right? A little bit harder than some of the other ones, right? Probably the easiest ones are the ones with the people who have the most distinctive features, like number 1 is Michael Jordan. Number 2 is Woody Allen. Number 8, very distinct Jay Leno, right? Very distinctive facial features. Anybody get number 6? This one's usually kind of funny. Okay, Tom Selleck. Robert says Saddam Hussein. Yeah, everyone thinks that it's either Saddam Hussein or Tom Selleck, right? And of course we wouldn't, or Castro, right? Of course we would never confuse those people if their faces were not blurred, but we confuse them when they're blurred because they have similar facial features that are distinctive. The big mustache, or El Chapo. It is Saddam Hussein. Okay, the reason that one is hard is because you are focusing on that distinctive feature and you're thinking of multiple people that it could be, right? Okay, so why is this relevant, right? It's because complexity of faces overlaps with another characteristic, which is visual novelty and familiarity, right? Which we haven't talked about yet. Kids with CVI find it easier to look at things and to recognize things that are familiar to them, including people. So faces are very complex in the first place. What makes people recognizable? It's very distinctive features, and everyone's features look different, and facial expressions change, and all of that. So the faces that are more familiar are going to be the ones that are easier to recognize. So kids with CVI tend to first only not look at any faces, and then as they progress, they may regard but not make eye contact, just kind of look toward or orient towards the most familiar faces. And then maybe they may regard some unfamiliar faces. And then as they grow, they may start to make eye contact with the most familiar faces, usually family. And then finally, not until way further on, do they make eye contact with anybody. Okay, so kind of related to this issue of visual novelty and familiarity. Okay, The fourth type of complexity, the last type of visual complexity, is complexity of the sensory or multisensory environment. And what you're seeing here in this picture is a little girl with CVI who is being repositioned onto a like a yoga ball by her PT and her her assistant, her aide. Within that picture, we have a lot of multisensory complexity. We've got tactile interaction. We've got struggling to maintain trunk stability, especially for a child with low muscle tone. You can imagine there's probably a lot of noise and things happening in the room. So there is external input and internal input that impacts sensory complexity. External input includes things like lighting, background noise, even the temperature of the room. If it's very warm, we tend to get drowsy, right? But that doesn't impact our vision. We can still see if we're drowsy. For a child with CVI, if it gets warm, they start to feel drowsy, you may see visual processing reduced. Positioning and trunk support are huge. In the positions or the, in the seating that requires more effort physically, we're going to see reduced visual functioning. In more secure, comfortable position, we are going to see increased visual functioning. So what that means practically is that expect less use of vision in PT, in gym, in a movement activity. That's okay. It doesn't mean expect no vision. I mean, it depends on the student. It just means focus on your PT routine, but don't expect as much use of vision. And we may have to plan the vision component a little differently. Maybe we're going to look at the red yoga ball before we move at all. Oh yeah, that's where we're going to go. We're going to go sit on the red yoga ball. Okay, are you ready? After we gave a quick look, now we can do the repositioning and we're not expecting vision during that. Okay, so in addition to external input, there's also internal input that impacts the sensory environment. That's just how the child's feeling, and we may not always have control over that. Kids who are on seizure medication, if they've just taken the seizure meds, the impact of the meds is that they're tired or they're irritable. Well, that may affect vision, right? And we just need to plan around that, and we need to be aware of it. One of the most common misconceptions about CVI is that children with CVI have fluctuating or variable vision. It's not the vision that's fluctuating. It's not that the child's going up and down in their actual visual processing. It's the complexity of the environment that's fluctuating constantly, all throughout the day. Unless you exist in a constantly controlled environment, complexity environment is constantly shifting. So it looks like the child's vision is changing, right? It was better yesterday. What was so different? What's going on today? Well, look around, right? Look around at the environment, but also ask questions, right? Did the child get enough sleep last night? Did you take the meds at the same time? This is why communication as a whole team is so important, because all of these internal and external factors have an impact on the child's ability to use their vision throughout the day. And this usually only gets addressed if there's like a crisis or a problem. But instead, we should be addressing it kind of all the time to just maximize the child's use of vision.
Hey,
Okay.
Chris, let's go ahead and do an interpreter switch, please.
Oh, perfect. Okay.
All
And I
right.
think we're at the
Thank you.
15-minute point. Yeah,
Yes, you're down to the 15-minute mark. Thank you so much.
definitely. Thank you. So the next characteristic is light. And we used to call this light gazing or non-purposeful gaze, but now we're just calling it need for or attraction to light, or just light, just the characteristic of light. And the reason for the change is that it's not just about light gazing. It's about a lot more than that. Light gazing usually tends to happen a little bit lower on the CVI range in phase 1, in early to mid phase 2, and usually it kind of stops, or the child only does light gazing when they're really overstimulated or really tired or something like that. Light gazing is just staring at lights, right? Bright primary sources of light, the ceiling light, the window, the TV screen, whatever it might be. Non-purposeful gaze refers to when a child's kind of not looking at anything, right? Just kind of looking off into nowhere. And we're not really using that term anymore because non-purposeful gaze is actually quite purposeful, right? it's not a good way to describe it. Non-purposeful gaze actually serves a purpose often of trying to attend auditorily or tactily. So it would be wrong to presume that when the child's looking away, they're not paying attention. In fact, I think it's usually the opposite. The child's looking away because it's too much to look and listen at the same time because of multisensory complexity. So it's much easier to listen or to touch if I'm looking away, and I need to do that. So you should never hear yourself telling a student with CVI, look at me, look at this, okay? And I know I've done it before too. So don't worry if you're going, oh no, I've been doing that. Instead of saying or prompting, realize the child's not looking because either they need to not look or because there's nothing adapted for them to look at. So if they're not looking, it's because we need to do something to support them to look, or because we need to just accept that they can't deal with looking right now and they're really trying instead to listen or touch. Okay, so light gazing. This little girl is looking up at the bright light. Why is she doing that? Because eating is a very complex sensory activity and she needs to be able to focus on that, especially if she has low muscle tone, right? And has some difficulty with swallowing and feeding, and it's a lot for her to deal with. So she needs to be able to look away. That's okay. Non-purposeful gaze, same thing. This little guy is drinking out of a straw. That's a multi-sensory experience for him. There's a lot going on there. He needs to be able to look away. Okay, so those happen for a reason. Also, just consider if you have a child who's in a Riften chair or an adapted wheelchair, and especially if they have low neck muscle tone and low trunk, voluntary trunk stability, they're angled at this, 45, whatever the angle is, they're tilted back in their chair. What are they looking at all day? The ceiling lights, right? And I don't know if you have ones in your area like we do here, but they're these terrible bright fluorescent panel lighting that we have in a lot of our schools and buildings. Now, if you're positioned like that and you're looking at that all day, of course you're light gazing because that's what you're used to looking at. So just consider that. Also consider that if you're showing something to a child who's at that angle and they're looking up like this, right? And so you're holding something right in front of them, that's actually their lower field. That's not their central field. You need to move it up this way. And if the light's behind them, you may need to get like one of these little black boards or something and position that in front of that light so it blocks it off. And now we can actually look at what we want to look at. So just consider those positions. Usually the best way to do that is just put yourself in the position of the child and see what does it look like to be looking from this angle. Okay. Now, I said it's not all about light gazing because as the child progresses in CVI range, they may no longer look at light, but now, just like with color, just like with movement, just like with the other characteristics, now they benefit from the use of light to enhance their attending. So they may actually start to look at more complex materials if they're backlit, if they have backlighting, or if they're illuminated with a flashlight. And I want to show you the same little girl who you saw earlier. I'm gonna switch here. Let's look at that same little girl who you saw at the table and outside. Oops, where'd it go? Against a backlit iPad. Looks like a totally different student.
Small, circle, big, circle. Small, circle, big, circle. Big, circle, small, circle.
Okay. Right? Kind of amazing to see that, right? We actually see visually guided reach. I'm not sure what game that is. We see visually guided reach. We see a pretty consistent, prolonged central visual fixation. Oh, cool. Michelle said it's small baby shapes. I'm not great with like knowing what apps are out there, but that's pretty good, right? It's not a very complex array, but the backlighting and the controlled environment, we see a much higher use of visual processing skills, prolonged visual fixation, eye to object contact, visually guided reach, finding specific places on the screen. It's pretty amazing. And we wouldn't know that she could do that if we only looked at those other videos, right? And it's the same student at the same time. Those are recorded at the same, the same week. So the next characteristic is difficulty with distance viewing. We're going to kind of we don't only have a few left, and they're going to go by a little quicker than those other ones. Children with CVI can often only look at things that are close to them, or they may be able to see things a little further away if they're moving, if they're bright color, or if they have bright lighting. So now we're seeing how all these characteristics kind of overlap. Sharon asked, where is she on phases? The last CVI range assessment that I'm aware of right about that time would have been late phase 2. She was probably like around 6 on the CVI range. Okay. Distance is actually the same thing as complexity. It's not just related, it's actually the same thing as complexity. And I'll explain why. If you are right up close next to something, in this case, a little bit blurry in the picture, but this is a bright yellow shape sorting toy with a little blue lid, and you put the shapes in. Now, if you're 2 inches away from this object, it's the only thing in your view, right? And nothing else is in the complex array behind you. If you back up 6 feet, now you're in this busy preschool classroom with this shelf with lots of things, and now we have a complex array. So the further away we are from things, the more complex the array is. The closer we are to things, the less complex. That's why distance impacts kids with CVI. But a bright color in a otherwise not very complex hallway may be able to see it from further away, depending on the student. Next characteristic, very quickly, is atypical visual reflexes. Visual reflexes can either be absent altogether, they can be latent or delayed, or they can be inconsistent. Sometimes there's a reflex, sometimes not. And there's 2 reflexes: a blink to touch between the eyebrows. It's that kind of like above the bridge of the nose, right between the eyebrows. There should be a blink to touch. It doesn't work if you try it on yourself, but this is a reflex that actually you should have at birth. It's actually a prenatal reflex that I believe it's I think it's like at 15 or 18 weeks gestation, a fetus has that reflex. So you should have that reflex at birth. If you don't, it's a sign that there's something going on neurologically. And the second one is blink to threat, right? Yeah, I was tapping my forehead. Yeah, I know. So a blink to threat, you can practice. Don't do it too fast because then you're getting air in your face. But moving your hand toward the child's face from different directions, try both sides, try at different times of day, and there should be a blink, okay? Obviously, there's no intervention that we're doing for reflexes. It's really just sort of a gauge to let us know where are we here. And we can see those reflexes resolve too. Okay, 2 more characteristics and we're wrapping it up. The next one is difficulty with visual novelty. And we already talked about this when we talked about faces. Children with CVI often look at familiar things better than unfamiliar things. They often look better in familiar environments. In typical visual processing, it's the opposite. In typical visual processing, when we see something unfamiliar, we actually want to look closer at it to figure out what it is. And we start to look at every little detail and we try to think, what is that? If you've ever seen, I'll show you really quickly actually, a picture of something that is totally unfamiliar, it makes you want to look closer. Further along the range, kids can see things that are unfamiliar if they share characteristics of familiar things. And then maybe we only have that issue with novelty in the most complex environments, like in a grocery store, in a supermarket. So complex, it's even hard to look at things that I usually look at, okay? In the interest of time, I'm not going to spend a lot of time on this, but this is just a meme that I found, which is like, name one thing in this photo. And it's like, I don't know how hard you can look at this. It's hard to identify what is going on here. But the point of this is that when I show you something like this, What does it make you want to do? It actually makes you put your head closer to the screen and really scan around. And you start to think and categorize in your brain, what is that? Child with CVI sees something as unfamiliar and chaotic as this, and it's like, get that out of my face. I don't even want to try to look at that. Can't even see that it's there. It's so complex and novel. Okay. Familiarity is easier because CVI is all about learning. It's all about exposure. Child with CVI has learned to look at what's familiar to them. Okay, and the very last characteristic here, and then we're wrapping it up, which we've already talked about a little bit, and we saw in both of those two videos with the blue little object in the dining room table and with the game on the iPad. Children with CVI often have trouble using their eyes and their hands together. And there's a couple ways that this might look. There is, the object is there and we look away and reach, or we look, reach, and then as soon as we're touching it, we look away, which is what we saw in the video with the blue little toy. Or you may see that the child doesn't look at all and they're feeling around instead. They know something's there and they're feeling around. And then as soon as they find it tactily, now I can look at it. All three are atypical ways of integrating tactile experience and visual experience. Now, I'm working right now on like a post for past literacy to explain this concept, but everyone always asks me the question, well, what about kids who can't reach? What about kids with motor impairments, motor challenges who cannot initiate reach independently? I think you really need to think outside the box here and consider my idea here. It's just my idea, is that visual guided reach is actually the same thing as multisensory complexity, right? It's about looking and touching. It's about simultaneous use of tactile and visual senses. And so for a child who can't reach, that's okay. It's really about, can they be in tactile contact with anything and look at the same time? Can they be using hand under hand, which is tactile contact? Can they look at something when someone's touching them or holding them or positioning them? Can they look at something when it is placed in their hands, right? Can they use that reach, or can they use that tactile sense and visual sense at the same time? Okay, there's that look away, reach. What you've probably noticed already as we wrap it up is that all these characteristics overlap. It's not just about color, it's also about color and light. It's not just about movement, it's also about movement and color. And just because something has bright colors doesn't mean that it's not complex, like that busy shelf on the right side. Little question there, will a parent's face, though complex, become familiar and recognizable to a child with CVI? Absolutely, and that's why usually that's the first one that we see in the complexity of faces, that a child starts to orient towards a parent's face. So